So I have like that whole roadcaster thing over here, and I adjusted some shit on it.
Oh, that's fancy.
What about this?
Hate that.
Let's just do a whole podcast like this. Ha!
Welcome back to another episode of 22 at the Lips. I'm your podcast host, Alexis. I'm so sorry. I don't know what just happened. I'm just so excited for today.
I'll be the sound guy.
Oh, if you have not met Ben Tacy, all the applause was for him. It was all for him, not for me. But Ben is no guest. I'm sorry, Ben is no stranger. You're not a guest. He is no stranger to the podcast. I've had him on. I've personally seen his performances in New Orleans. If you've ever been to the Cat's Meow, just imagine Ben Tacy. It was quite a spectacle. Highly recommend if the video ever surfaces again. But
It's still on the Master Medic's Instagram page. It's
it's good though. It's so
I guess
good.
it's part of being. I didn't realize that part was in my contract that I didn't have to like approve of incriminating evidence to be blasted on social media. But here we are.
We all got a good laugh. It's okay.
Yeah.
You'll be fine. Um, but Ben has been doing this job a lot longer than me. He has a lot more credentials than me. Highly respect the guy. But with a lot more credentials and a higher pay grade and all of the other good things that Ben has that I don't, he has a lot more experience. And with the topic for today, I have my 2 cents about it. I have my own viewpoints about them, but I wanted Ben on to talk about refusals. What are they? Why do we need and sometimes really don't need them? How can we mitigate the process of, well, my patient should go, but they don't want to go. What do I do? So, Ben, what's your outlook on refusals? Like, how do you go about them? When is the right time versus when is the time to stop trying to coax your patient into a refusal? And we'll put a pin in that because I have a whole soapbox about that. But
First, so with some background from like administration side of things, right? Or like clinical review and QA/QI, hands down, reviewing refusals is one of the biggest litigations that EMS will ever see is with that. I mean, there are more, maybe it's anecdotal. I don't have any hard data on this, but there are more litigious issues with refusals than there almost is like malpractice, right? Of, oh, I gave the wrong dose of medication, right? So it's more of a um like a human error aspect than where refusals come into play is, if EMS is held to a higher standard, they almost look at a mishandling a refusal is a lack of empathy from a professional person,
yeah,
right?
um,
It's just, I don't know if it's a thing we'll ever get perfect, but there's just it's just a complete pain in the butt having to deal with those, and station call-ins of, or when the worst when it gets to that patient was a refusal, and oh, we're going to that same address the next day for a DOA. That's when things get really, really sketchy.
I personally have been the medic that responded to. It wasn't the agency I worked at, it was our competing agency. They were there 20 minutes prior to our call for a lift assist is what they called it. We got there quite literally 20 minutes after they left, and the guy was coded on the ground. We couldn't get him back.
Oof.
So, I think I think with the freedom of us having the opportunity for refusals, it's the same thing of kind of like you talked about, like forgetting a med dosage or forgetting how to do a sling and swath or something like that. Like we have the tool in our toolbox, but it can be abused. So like especially I think it's also hard whenever like this could just be me, but like law enforcement, they know the rules to the refusal. They know that we can't force anybody to go, but because it's not their name on the paperwork, they don't look at it the same way. So they're like, "Well, they need to go." Correct. Even talking to family members, "Well, I think they should go." "That's great, ma'am. Your mother doesn't wanna go. Our hands are tied because, yeah, we also think she should go, but she meets the specific criteria." So, like, we've talked to her. There was one time was on scene for 40 minutes because just trying to explain to Meemaw, like, "I know you don't think you need to go in, but you should." And I don't like spending a lot of time on scene in general, but, like,
Same.
when it comes to, "Hey, when I leave, you need to understand because my blurb on my refusal reports is long and lengthy." And it's the same thing I tell the patients of, "Hey, if we leave and something happens, we tried to get you to go. We tried explaining why you should go. If you decide not to come with us, it's on you." Now, granted, when I go to that car wreck and I don't even know which car is involved in the wreck because all look fine, I'm not gonna sit there and be like, "If I leave, you could die." No, I'm not doing that.
It's such an infamous statement, like, you realize if you don't go with me, you could die. Like, oh, we try to fear of just put the fear of death into them so we can generate a bill or, like, what is that? Like, I don't like,
It's
please
another form of kidnapping.
please go with me. I signed too many people off, and my supervisors are mad at me. Please go with me.
I can't help the refusal rates, talk to other people. Um, no, and there will be moments when you get to the patient and you know things aren't good. I've had the patient that having a full-blown STEMI, like, it made, the hairs on my neck stand up, and the patient said he still didn't wanna go. So, I mean, when you come to that roadblock, "Okay, sir, but you do understand your heart is dying." "Well, I don't wanna go. I'll go in an hour." "Sir, you may not have an hour. I don't think you understand." They still don't wanna go, but you still have the tools in your toolbox, and is it sounds terrible, but once you once you fulfilled your end of the deal of you've educated the patient, you've explained why their medical situation is horrendous or they need to be evaluated. Maybe it's not a STEMI on the 12 lead, maybe they're not having an active stroke, but it's something that kind of makes you, cock your head a little and say, the math don't math. I don't think this
Mhm.
is okay. You should go in. You have to be able to walk away knowing that like you did everything you could, but from a legalistic standpoint, you can call your supervisor. You can call OLNC, call the nearby ER. And I like to have my signatures include a police officer as a witness, my partner as a witness. And sometimes I've had to do it, call on the nearest ER doctor and saying, "Hey, look, I had this patient. If you want to talk to them, maybe they'll listen to you." And after that point, if you still don't want to go, I'm gonna tell you, I wish you would. It would make me feel better. But like, man, I'm not gonna argue. I'm just at that point where I don't argue anymore. Family starts getting upset about something, I'm not gonna argue with you. No, it's such a hard I don't know, hard path to travel down of like you have that patient that really should go, they need to go, you're gonna be thinking about it for the next 3 hours of man, I hope they're gonna be okay, but it's their decision. I mean, they know they're signing it. I refuse to go despite medical advice. I am leaving my favorite one. I am leaving the hospital against medical advice, and it's my own responsibility. And I don't know. I don't look good in orange. I'm not made to be in prison or jail or both. I forget the order of how they go. I'm not made for that. So like 90%, I don't want something to happen because my patient doesn't want to go and I didn't explain to them correctly. 10%, I'm not trying to go back to court in the next 3 years because I'm not going to remember. I'm not going to remember why I got a refusal either. So
I
my
don't even know what I
question.
had for breakfast, let alone what occurred on that run 8 years ago, right?
um, when are the moments when like you can look back and you're getting that refusal and like you're trying so hard, but the patient still doesn't want to go and they need to go. Like what's your go-to spiel? Because mine is always like, well, if you were my mom, or if you were my dad, if you were my brother, if you were my insert vague relative, just like my thing is I want you to understand, like, I don't want you to go so a bill can be generated and I get my paycheck. I don't care about that. My paycheck is still going to be trash. It's not really trash, but it's still not going to be great whether you go or not. So like I'm here for you, sweetheart.
Yes, we are. Uh, I don't know. I think one thing that really helps me, I believe, or one thing I try to really push for and seeing is educating the patient, like on you don't throw out, speak to them in plain language. If you throw a bunch of medical terms, they're gonna feel like that you're just trying to talk down to them. Be on their level with things. So if you really feel like that somebody is um like I remember not long ago I went to a call and it was, you get that emphasis one, it's like, callers requesting a silent approach that the actual patient has no idea you're coming. So you're met in the driveway by family and they're like,
Oh,
all right, listen, she's gonna get really pissed off because she didn't want us to call you, but we did anyways. And that always starts everything off with a bang,
I'm also
right?
about to get
And
pissed off.
yeah, and then there's one in particular, like, I mean, it was, I mean, my field diagnosis, because EMS does diagnose, was like the patient was septic. I mean, they were fevered, their blood pressure was low, and like trying to explain how all this really works and what they're going to expect. Um, yeah, and inevitably we run these calls where it's like you don't need an ER, right? But in this particular, like, well, I'm just gonna go up here to the urgent care. I'm like, please don't, because they're gonna call us again to come get you there. And like this is the process, right? So I think explaining to them, you know, what's gonna go on, why they need to go there, and maybe what's happening with them to try to advocate for them and have that empathy, right? Or using family, explaining to them if the family is trying to go that we if we truly know that this person needs the care of an emergency department and it's beyond care of something I can do to treat in place, if you will, to kind of get them stabilized, get them, make sure they are okay, and kind of help triage them to where they need to go. If we've triage made a determination that they most definitely need either maybe the local ER or there's a specialty resource center that they've got to go to. So explain to them in education, in layman's terms, of what's going on and the true risk of what could happen, not the fear of things like if you don't go right now, you're gonna die. Just being like, this is something you most definitely cannot treat at home. That's
Mhm.
gonna require you to probably have IV antibiotics. Yeah, you've been on oral antibiotics for a week for that little bit of cellulitis you had. Well, sir, your entire right leg has cellulitis now. It's not just in your knee now; it's everywhere. Right? Not in that septic case, but
Yeah.
explain things to him that, hey, maybe there's some things that you've missed, or just really trying to educate them and truly give them an explanation of what's happening and worst case scenario. Right? Ultimately, death is always worst case scenario, but no, we got to put stuff into a real aspect,
Yeah.
right? And to let them know, like, you definitely will need this. And I mean, and ultimately, sometimes we can't make them go, right? So I think that from like a lawyer's standpoint, right? I've read a lot of publications and trainings that lawyers have put out, and one thing they say that most refusals lack is any sense of empathy, right? That like I explained this, in link to the patient, that, tried to advocate for them, tried to explain it to the family, encouraged, and warned them, and did this, and you did full assessments, and you really did everything in your complete power to get them to go. If you're just like, went in, patient had this complaint, they didn't want to go to the hospital, signed refusal, return in service, right? There is no signs of empathy there. If something ill happens to that patient, you're going to get hung out to dry on that, right? So and with the documentation thing, that could be a whole other podcast in itself of adequate documentation. But yeah, but in the long squirrel conversation of that, I think just educating, talk on their level, and show compassion to them. Those are the things that help me advocate that when the patient definitely needs to go to an ER, I'm just going to try to give it to them in layman's terms.
And there's with the aspect of educating the patient, I think there's a fine line between the refusal always has to be the patient's decision at the end of the day. But we all know we have those calls that my most recent one was my mom got diagnosed with COVID 2 days ago when she just had her first symptoms. So 2 days later, she still feels like trash.
Mhm.
And all of her vital signs are stable. Everything looks good. She's ambulatory. Just sitting down and being like, look, sis, I understand you don't feel good. I understand you can't stop coughing. The thing is, with you having a positive diagnosis of COVID, blah, 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 but also setting it up for that last finish remark of, but it's completely up to you. If you feel like this is something that you need to get seen about, my favorite is, you know your body better than everybody else.
Your
Just 'cause
body, your
I
choice.
just 'cause, like, I don't want it to be a thing where, "Oh, well, the medic said I shouldn't go." I n never couldn't be me, not
Mhm.
me. Um, I don't know, but like you said about the empathy, if you go into a call already expecting a refusal and it starts not going that route, you get a little pissy. Um, but also in that caveat, like, if you're spending 20 something minutes talking to the patient into a refusal, or you could have already almost been to the ER
Yeah.
by now. Like it why are we still sitting here? But my last little note is I like to ask whenever patients already start down the route of like, well, I don't want to go. Why? Just I'm being nosy. Just let me know why. Because sometimes it's finances. With the beauty of our healthcare system, um, people have to worry about like, well, how am I going to pay for an ambulance? It shouldn't be like that.
Right.
Um, it could be I know for a lot of older people, who's gonna watch my dogs? Who's gonna watch my house? How am I gonna get back home at the end of all this? It could be just the fear of what's next. I had a patient who I had the tablet, it was turned towards him. I'd been talking to him for 30 minutes and he still didn't want to go. Turned the tablet to him, he was about to sign it, and I just put away. I said, "What? Like, are you scared? Like, what is the drop?" I mean, my man's was involuntary, like his whole shoulder, like jumping up and down. No pacemaker, no
Oof.
defibrillator, just weird. I remember like looking at him as he's about to sign, and I was like, we can't leave him here. Like, he can't sleep. It's 3 o'clock in the morning. Can't leave him here. So, like, just having that moment, kneeling down beside him, and I was like, sir, if you're scared, it's understandable, but you can't be scared and be here. We ended up bringing him to the ER. And I counted that as a win for myself because, like, oh my God, am I the patient whisperer? But also, like, he got admitted and ended up getting transferred to an entire, like, neuro specialist center. That's not a win for me. I just got him to the ER. But, like, if he had stayed at home, and you don't want a hypothetical scenario every single call because you'll never sleep at night, but, like, if he would have stayed home, what would have happened? Um, I don't know, I feel like I equate the use and ability to obtain a refusal the same way as we have the responsibility to understand the dangers of ketamine. Ketamine's not that bad of a drug when it's used right. Refusals can be a great thing when they're used right. Do we need to bring in Meemaw, who had a blood sugar of uh, telling you how low the ground is? It's very low. We fix it, and now she's eating her peanut butter jelly sandwich, talking about her cats and her grandchildren. Meemaw don't know she don't need to go to the ER. That's going to take an entire EMS unit out of service. It's gonna hole up a whole ER room that nobody can afford to have just nilly-willy and available, and then Meemaw's gonna get that bill later on for the ambulance in the hospital. That's not fair. It's not fair to everybody. She don't need to go. But your patient who they say the 5 magic words, and they have to be brought because they said those 5 magic words, you are legally bound, you can't leave them there. Probably shouldn't be getting a refusal on them. Even if they are AN04 GCS 15, you can't stay here now. I think our most common one are overdoses. Um, my personal theology is that if you give them so much Narcan that they're conscious, you could have saved yourself a whole headache by just getting them breathing again and then letting the ER deal with it.
Yeah. Yeah, and
Because
we
you'll
have
probably be back in 3 hours to do it all over again.
yeah, and, it plays into that same point too of and I think some of those calls that you encounter have a huge bearing on, like, the socioeconomic status of wherever you may be, right? In lower socioeconomic areas that maybe they don't realize that they can go to various clinics or where they're at. They just and I've picked up several patients to say they doctor at the ER, and they're like, "Well, I'll just go
Mhm.
there."
Yeah.
And I don't have a vehicle, and I mean, and that sucks. Like you're at the point where, hey, you
Yeah.
could go to a physician, but you don't have transportation. You have no friends. You have no family. That is quite a predicament, right? And you have to have some type of sympathy for them. But then you show up to the house and there's 8 vehicles in the driveway, and it's like a well kept
Oh.
place, and they just have that. They have that need for instantaneous gratification where they're like, well, if you take me, I'll get seen faster. Like, it's such a huge common misconception. It's like they feel like
I'm
they need to be seen right now, that they don't think that an ambulance can transport you to the triage. Well, sorry, Karen. Yes, 100%.
I was about
We
to
can
say,
take you to the waiting room.
I am quick to pull that out if it's starting to, and granted, it's not all the time that, but when I'm trying to pull into a driveway because you called 911, our job is not always flashy lights and sirens and adrenaline, but, like, man, if I can't even get into your driveway because there are so many cars and everybody still has a pulse and is still breathing normally, I'm a little mad. Imma be so for real, I'm a little mad. But, I am quick to tell people, like, if it's starting to set up and ram up like that, just because you go by ambulance doesn't mean you're not gonna go to triage. Just want you to know before we get there, there's a large possibility you will be brought to triage depending on how busy the ER is. 'Cause the ER is always busy.
Yes, 100%. That's we ran a call the other day that, and it was like a mild chest pain call that, guy admitted he had anxiety, but everything had resolved. And once he found out his blood pressure wasn't nearly as high as what the wrist auto cuff told him it was,
Wow.
then his anxiety settled. And he's like, well, if I should probably go get checked, and I'll just go with you guys because then I won't have to wait. We're like, well, sir, can't guarantee that. There still might be a wait. So you might, whether you go in your vehicle with ours, you the wait may not be any different,
Mhm.
right? But some of that still goes back to advocating for the patient because some people are completely naive to that. And they're so scared that they call us, right? So, and we have to keep that idea too that when people call us, they believe that we are the professionals, that we know everything and we can fix all problems. And they might call us just like, I don't know what to do. And then you get there and it's just that healing hand, like, ma'am, it's gonna be okay. Like I have a
I love
band-aid
it.
for your small nick on your finger. Like it's okay. I'm here to reassure you, and then it's okay. right?
No, ma'am, your finger is not getting amputated,
Right,
correct.
like, n no, that will not require stitching. Here's are you sure you were bleeding? Because I don't see any blood. And but, we have to remember too that we go to some of these calls, and that's what the people cause because they are freaking out. And, to us, we have that relevance, right? That we think that, "Oh my god, like, I've seen so many bad things in my life," not on that stance, but, we keep in mind what we have seen and experienced versus what they may have seen and experienced. This truly could be the absolute worst day of their life, and they think their world is coming to an end, and to us, it's a Tuesday afternoon, right? So, keeping in mind that we get there and, like, they might be freaking out that they are dying, and it's like, "No, sir, that is indigestion." Okay. The big
Those are the
Slurpee,
12 burritos you had for
yeah,
lunch today.
the 7-Eleven Slurpee and the grande meal from Taco Bell, maybe not the right choice. Or,
No, that could be it.
just but, some people just cause for consulting and to help calm them down. So then we have that, but then, well, other than that, there are those people who are just stubborn, like, "Well, I didn't call you at 3 a.m. because I figured you were sleeping. I didn't wanna bother you." It's like, well, bless your heart. I wish you would have because it would make my job a lot easier at 3 a.m. when you still had that 2 liters of blood inside of you. Okay.
Mhm.
Yeah. So um it's such a mix, right? So I've worked at agencies from every type of demographic you can imagine of, multi-million dollar homes to places that don't have floors in their buildings. And it's just night and day difference, right? Of places that have, live-in housekeepers in these million-dollar homes, and it's just immaculate. And they're so apologetic for the mess because their house cleaner was off sick, and there's a sock in the middle of the floor. I mean, like, come to my
Right.
house and see what my 3 kids do, right? And then you go to another place that's a complete hoarder house, and they don't care. They're not apologetic whatsoever, or they see nothing wrong with their living conditions. So, you know, the fact that, socioeconomic plays into this so much, as well as just the general, psychiatric well-being of these patients,
Yeah.
so much goes into what their mindset is when they're calling 911.
Um, I was listening to it was some EMS conference that was going on. It was like one of the mini sessions, and it was like the live version of it. It was weird. It was cool, but it was weird. And it was like the what was it called? It's like the female patients you may encounter, something like that. And I was listening to it, and like the speakers were just going on and on about like, well, in females, abdominal cramping could be this, it could be that, and like, yes, but also, why are you calling 911? And I was very crusty. I was so burnt out. So they were like, we're opening the chat for any questions and discussions. And so I commented, I was like, how do you not get frustrated? Like, at what point do I not look at my patient and say, no, you don't need to go to an ER because it's your time of the month. Like, no, ma'am, get off my stretcher. And the speaker, she was like, look, I get it. It's a hard spot to be in, even harder when it's 3 a.m. and your patient's sleeping on the way in. And it's not just this, this demographic or whatever, but like in general, the ones that call because they have back pain at, whatever o'clock and they're asleep by the time they get to the
Yeah.
hospital, but they're hurting so bad. But the speaker said, she was like, you know what? When I pick up patients that I think they have a ridiculous complaint and it seems very dramatic, she says, I just remember to myself, like, this may be the end of the world to them, but how lucky am I that I get to live a life where I don't feel the need to call an ambulance for this problem? And it felt
Yeah.
like a punch in the face. I don't always have that attitude. I didn't this morning at 4 a.m. when one of the nursing homes called because Paul Joe pulled his catheter again. Why you
Oh,
messing with the man at 4 a.m. and his catheter and looking at him? Let the man sleep. Okay. The whole drive there was, I hope he's nice. I need a paycheck. It's almost time to go home.
yeah. Yeah, and I'm sure like none of the listeners have ever had run of that, skilled nursing facility call that can't handle the catheter that came out. at 4 a.m. that's actually
Head
been
to
deflogged for 12
cadavers.
hours, right? So, um, and inevitably we get those people dumped on us too, right? So it's nice when you can get into those facilities and the patient's like, "I'm not leaving. I'm fine." And they're like, "No, you have to go." And that's what
Actually,
sucks.
they don't.
Yeah, and I've been in those situations
Uh-huh.
before too, where it's like both sides of the fence. Like you have a patient that does not want to leave in nursing facilities. Like you have to go. The doctor said you have to go. Like, well, I don't want to. Like, if you don't go, that's in the contract that you have to go at doctor's recommendation, or we're going to kick you out.
Oh, that makes me sick.
Right. And then I've
That's
been on the other
disgusting.
side too, where like the patient somehow, like their family smuggled them in a cell phone that they're not supposed to have, and they've called 911. And the nurses are like, "We're sorry they call. Like, there's nothing wrong with them." And are like, "They're mean to me. The turkey tastes bad. I want out of here." And like, "Take me to the hospital." And there's like, "You can't leave. If you leave, you don't have your bed back. You can't do that to me. I pay for this bed." And you kind of get in that situation too, where it's like, oddly enough, it's like, yeah, this is not a nurse jab, but it's kind of like, "Hey, I'm actually on the nurse's side with this one. Like, you shouldn't leave." Some other times it's like, "What nurse? Why am I here? I don't understand." Like their creatinine levels were up in blood work that you took 4 days ago. Sure. Okay. And when'd you get those results? Oh, 8 hours ago. Oh, okay. That's cool. Right. And so we run into those just everything imaginable. Like they need to go. They don't need to go. Why am I here again? Wait, who called 911? Nobody has any idea who called why I got here. Right. And the smart inside of me says, I go to this nursing home and they're like, "Who are you here for?" And I'm like, "How many people need to go to the hospital?" I don't know. They don't give me names. They gave me an address and I'm here. If you have multiple people, I can take two. Okay. I'll make
Dude,
us like a little party bus. I'll take two with me and that's about what we can do. Right.
it
But
always blows my mind when they're like, "Oh, who are you here for?" I've got to the point where I look up and I say, with all due respect, I have no clue you guys called. We don't get any of that besides a room number, and we don't even know how to get there because this facility is Narnia. It's the
yeah,
labyrinth. I hope we make it to the patient. I would also like to leave at the end of this, so I hope we don't get lost. Um, no, it's that weird fine line of at what point I don't know. I like the fallback of like, if it's not something that it's acute, if it's not a reason why we're called emergency medical services, with all due respect, if it's not something that indicates going to an emergency room, they have a neurologist appointment tomorrow at 9 a.m. I mean, you should go get checked out, but also you don't want to miss that appointment tomorrow. But then it comes back down to, like, you as a provider. How thorough are you being, and how much are you doing your CYA? Because, like, you can go in, have a nice, lovely 5-minute chat with your patient. You assess that they're ANO4, GCS 15, get your refusal. You didn't even touch the patient. You didn't put a single hand on them. You didn't do your first single assessment, and you completely missed whatever it is. I'm not saying refusals are bad by any means. Sometimes they are necessary. I don't want to go to every fender bender and just be under the general impression that because you got struck at 20 miles an hour and you've never been in a car wreck and you're wondering why your neck hurts. I'm mm, that's all I'm gonna say.
yeah,
I just
understandable. Understandable.
oh no, you don't want to go. Please sign here.
Oh no, your check hurts. I mean, okay, your neck hurts. I mean, yeah. And
um,
there's I don't in that line too, like you have these people who they're like the refusals of I don't want to go to the closest hospital. I want you to take me to go drive past. It's like in our system, we're pretty rural, so they're uh, you legit have the ability to. like go to a higher level hospital, and on the way there you may possibly drive past two other emergency departments,
Mhm.
and that's all still all considered like insurances of like in the service region. So they're like, well, the insurances will pay so the patients can pick where they want to go, which is crap, right?
Yeah.
And there's nothing we can do to say no. We can't tell a patient, no, you're not allowed to go to the emergency department. And we also don't have the ability to say, I can see the emergency room over there. Like, if you permit me, I'll hold your hand and walk you there because you already walked 8 miles to get here,
I
right?
wish.
That just go right there. You have a cold. You can probably go there. You don't need to go to the level one trauma center that is also a
Uh-huh.
comprehensive stroke center for your sniffles, right?
Yeah.
And and it sucks because there's nothing we can do. Then all it does is back up that network, right? And but and there's just no good way to deal with that except to explain to patients that, hey, there's a good chance that you're going to wait here for a good while. But still, if they say, nope, that's where I want to go, that's where they got to go. And that part is that part sucks to like think that, hey, I have to add an extra, 30 minutes one way to take this patient to the hospital they desire because they say, well, my doctors are in that same city. Well, conveniently,
Mm-mm.
you're not going to see your doctor. You're going to see the ED physician.
I am
You're going to
quick
see the resident or the attending, and that's who you're going to see.
when they bring up that line, I'm quick to tell them, if you did not call them and they verified they are at the ER, they will not be at the ER, especially when it's 2 o'clock in the morning. They wanna go to that hospital, don't have this problem anymore, and it makes me so happy. But they wanna go to the hospital that's 30 minutes further and pass up the very reasonable one that is on the way there because that's where all their records are. And I've looked at patients and I'm like, you have the same records everywhere. They can pull them up at this hospital. Well, I don't like that one. Okay, well, we were just there and we sat and waited for 3 hours and we can't do that again in this shift. So just so you know. I
Right.
don't
And
get sassy and, like, not trying to be mean, but, like, I don't want you coming back and being mad at me because I told you it's gonna be a wait. You'll get seen faster at this ER who can still handle everything you need, but hey, it's your decision. Patient
right,
choice.
and another downfall of some of these things is like a scenario thing about in this aspect was I got involved in a clinical review of a case where ultimately the patient died shortly after they went to the ER, but they refused to go to the local ED because of such terrible experiences with them. Now, mind you, they would have been 5 minutes approximately, if I can remember right. So, like 5, 6 minutes from the local ER that's like a non designated. They have the ability to admit, but they refused to go there because they had such poor experiences there that they wanted to go to a much larger hospital that would have that added nearly 25 minutes to the transport. Yeah, they're alert oriented, but like vitally, they were unstable. They were CPAP'd and everything. And ultimately, I think the patient died within like an hour of arriving at that receiving facility. And no doctors want the patient to die in their ER. So now it results in this whole big review of like, why did you bring them here? You legitimately took this patient past two other ERs that could have aggressively managed this patient airway and they might still be alive. So then it goes back on the provider. And luckily, this provider like did some stellar documentation of like showing the empathy and the advocacy and stating the patient refused to go to the local ED. Like we told them that they may not survive to make it to their desired facility, and they were willing to take that risk because of such terrible experiences that they felt like they would die regardless.
Wow.
Right, and, like, how bad that sucks to have that on your shoulder that a patient can make the decision that you might know, I don't think they're gonna live to make it there, but that's could be their final wish.
Yeah.
And that sucks on us that we know, "Hey, I've, had this patient before multiple times, or I've been in this situation, and if I don't take them to this hospital that can control their airway or get them this or have this thing happen, they're going to die." And luckily, in this case and instance, their documentation was immaculate, and that was their CYA. It really covered their butt. But then, a lot of people in the receiving end were like really hounding in and like as an agency as a whole, just bashing an agency because they made it sound like if they electively chose just to let that patient die in their lap or that extra transport time was the reason that they died. And they could have went to the local ED and still died. They were in, terrible extremists, but it's one of those things like sometimes the patients has the final say until they can't.
Mhm. Um, Having had the patient that, uh, on the way to the level 1 trauma center, we passed 2. Yeah, we passed 1 for sure, like, freestanding, nothing crazy. They can handle a lot because that's, you know, the area, but, like, they can't do much besides the CT and an X-ray. Pass that one, and you're supposed to pass it's like a not a trauma center. They can take anything because it's an ER, but, like, their specialty is, like, your STEMIs, strokes, things like that. Then you have your level 1 trauma center, which you pass the other 2 on the way there. Had a patient who we were booking it to our trauma center, um, and then we're about to pass, you can bring them here, it's just not recommended. We're about to pass that hospital, and I told my partner, I said, "We can't pass it up. Like, I'm not she's just gonna croak with just me back here by myself. We have to." And I mean, making the executive decision sucked, but, like, we got her there. The doctor was pissed. The nurses are unimpressed. Just
Yeah.
nobody's having a good time. I'm already calling the supervisor because I'm like, "Hey, I just almost punched a doctor in the face. It's not a good time right now." And, like, the lady passed away there, but I went back and talked to the nurse, and it's a week later, and I'm still crying over it, and I was like, "I promise I'm not stupid. I know she needed a trauma facility. I know the nurse was like, "She would have died on the way there. Like, whether it was here or on the side of the road, she was gonna die regardless." So, like,
Right. Yeah.
it's a hard spot to be in, but number 1, good documentation. But also, like, if you can clinically think it through and justify the things you do, okay, do you, boo. It's part of the, patient advocacy
Yeah.
aspect
There
of
you
what
go.
we work
Like
in.
rationale and justification are everything. Right. And in the same thing of, putting that in our lap of like us justifying or us making the decision when they say, I don't know what to do. Right. So it even goes beyond go to the hospital algorithm. Yes, no. Right. And it's like, I don't know what to do. Where do you think they should go? Right. I've sometimes asked that tough decision on us. I recall it was a call that I beat myself up over for a while. It was one of the times like, really, really sick kid, right? I mean, like on the brink of death kid. And some backdate in this scenario was a kid who was like 6, 7 days post op from a grade 4 liver lac from a motorcycle accident, like 9 years old, 9 or 10 years old.
Oh, wow.
Kid had no palpable pulses, no cap refill, white as a sheet, was still alive. And so make a decision. We're 10 minutes from a local hospital that has some minor surgical abilities and has blood, or we're 35, 40 minutes from the level 1 trauma center that treated him and to get him there where he's going to need to be opened up again and have surgery. So then the decision came in of, hey, where do you want to take them? And even having to disobey a supervisor, a shift captain at the time said, "You need to fly him." I said, "He won't live that long. Like he won't live to a landing zone. I can be at a landing zone in 15 minutes or the local hospital in 6 minutes. We don't have that much to compromise." And the only thing he's able to do, start an IV, yeah, get some crystalloids started a bit, and yeah, and then the kid got into the ED and ended up developing ARDS, ended up getting like basically a complete blood transfusion at that ED. Um, the helicopter, I think, had to wait They called a helicopter to fly him to the trauma center. The helicopter ended up waiting like an hour and a half for them to try to do something with this kid. Uh, and beat myself up really bad over that. Like maybe I should have had them go to the level one trauma center to begin with. Then ultimately, coolest thing ever. Maybe not ever, but kid lived. So awesome story with that. And then I got a letter from the head of the emergency department at the level one trauma center and to like our department, not to me. It said, you know, EMS, has its pros and its cons, and it was worded really well. And but basically said, sometimes the best thing a provider can do is just to make the best decision. And ultimately making the decision to go to the closest hospital instead of the biggest hospital is inevitably what saved this child's life. So it was like, oh,
Oh,
okay, I
that's a
did
big
good. I
deal.
did good. Yeah, and it was like
I
week
won't quit
later.
my
But
job.
yeah, and it's like, yeah, and it was just it was one of those things. Then it like weighed into because like it was a crazy story because the child in question, the patient will say, um, was actually it was a call into station because it was a child of a guy that was working. It was like one of their neighbors and a family friend. They're like, "Hey, can you guys come up here and look at this kid? He's not right." And that was a physician that called in station and said, "I think you guys should come here. This kid's sick." And we go up there and the doctor was
Oh.
worried, like, "He's bad." I'm like, "Oh, okay.
Oh,
You're right.
no.
He is bad." So yeah, I mean, we get so many decisions put on us, right? Like, and you make that kind of tough decision of like the decision of me where to take them is gonna inevitably change the direction of their life forever. Why do I not have the same decision ability making to say you don't need a hospital? If I can choose of what could potentially save your life, why do I also not have that to say that I don't think you need a physician right now? Um,
Yeah.
so
No,
kind of a very
100%.
much double-edged sword.
That's good. I'm gonna write that and keep it in the cranium. That's a good one.
Yeah. So I know my story was kind of long-winded, but that's eventually where I was trying to come back to.
Yeah.
Like,
No, no, no,
again,
I would print out that letter and put it on my wall, and then I put it in my car. I would blow it up and put it on the roof of my car as like a, "Hey, you did something good. Congrats."
yeah, does not happen much. I mean, I got like a couple little, "Hey, you did great" plaques and stuff back here, but it's those handwritten letters that mean the most. But and
Oh,
there's in the aspect of refusal, there are some states out there, or not even says necessarily states, but some services that are doing such things as like, "Hey, I don't have a ride. This AMS is my only ride." Like, well, if you sign this form here, I will give you a $15 Uber voucher that will take you to the hospital, right? And some municipalities are funding this, or like just
I'd fund it
calling
with my own
taxis and
money.
paying for it. And like, hey, we're not gonna. Hey, if we do the math, all right, we got this paramedic and an EMT, and they're paid X amount of dollars an hour, and I got a $300,000 ambulance that's going to be out of service for 30 minutes, and it basically costs us, $200 an hour to run this thing. Well, they're going to be out of service for an hour. That's $200 wasted that we can't probably even bill for. They won't pay the bill.
Yep.
Let's just give them $15 to get them to the hospital. Or hey,
Dude,
here's a
I
bus ticket.
I would pay for it with my own money. And it's not a matter of like, I don't want to run calls. I mean, granted, right. But if it was that way, like, I would just get out of this field. It's literally your job to run the calls. But like, it's like you're talking about just the patient advocacy of like, hey, look, and logistically in our job with the thinking of we're putting you an EMS service, we're putting an EMS ambulance out of service. This patient's going to get a bill. They're going to have to sit in the ER. That's the ER room that's getting wasted. It's an ER doctor. And then if you bring that patient in and the ER is full and they get put in the trauma bay room, then a trauma comes in. All of this, it's not always going to happen. But like, it's the things you got to keep in the back of your mind. Again, we can't tell a patient, no, you can't come to the ER. If they're acting a fool, we just sedate them and call it a day. But like, we can't tell people, no, you don't need to go to the ER. And if you do, shame on you. Just you deserve a write up. Shame on you. But we can coach people and explain like hey, this has been going on for 5 years. We can still bring you in. The ER may do some tests, but they may also not. But if you have a primary care physician who has been attending to you for so long, that's more recommended over an ER doctor who's starting over from day like step one, and you'll have to redo all of the same test all over again.
Yeah, and educate and Tanner, back to that educating the patient thing, right? Like, hey, my blood pressure's been running a little bit high. Can you take me to the ER? Like, well, are you aware that an ED physician is not going to treat your trending blood pressure? Like, yeah, I can take you if you want to go. Like, no qualms about it, but that's not where you need to go. And ultimately, you could be wasting your time. So I think having that knowledge of really what goes on in the hospital system is is a thing that should really be understood and part of the whole clinical process of your education, right? That you're kind of learning how the whole system works so you can advocate for that patient. So they're naive to some of these things like, oh, my blood pressure is high. I'll go there and they'll write me a prescription and then I'll be good. I'll get this under control. And they don't, that they will have to refer you to your primary physician where hey, maybe you need to go to, this local clinic, and telling people they don't even know. I've had several patients like, well, my primary doctor can't get me in, or I just moved here and I don't have one. Like, well, hey, great. There's this clinic that's a walk-in clinic. They can become your primary care provider, and it's right up here. Here's directions. And I've had that before. Like, oh, I had no idea. I've tried been finding a doctor. I'd never even heard of this place. Right, and sometimes that's it, and unfortunately, they've had to call 911 to make that happen, but, you know, it's, I don't know. If I was king of the world, I don't know how I would resolve that.
I wouldn't be worried about this job anymore if I was king of the world. Um, I don't know, and I think if abused, if not used correctly, refusals can be such a slippery slope. Um, Especially, man, you get that call 20 minutes before your shift's about to end, and the patient is teetering between, I don't know if I want to go, or Mima fell and she takes the blood thinners and
The
she
blood
can't
thinner.
remember the fall, but like she knows she fell. But Mima's fine right now. I just, oh God, if we do this just right, we can still get off on time. That's dangerous. Do I think every Mima or people who falls that takes blood thinners needs to go to the ER? No. Do I want that on my conscience? No. Just get in. Get in. We'll take two blood pressures on the way there. I'll call the hospital, let them know we're coming on in, and then we're done. And now it's not my liability.
You wanna know the refusals that probably scare me the most? Is those domestic refusals, right? Where they got
Ugh.
in a fight, they said, "I'm just gonna kill myself." And you show up and they're like, "I never said that. I never said that." And they're like someone's like, "I hand on the Bible. I swear to this, everything in my life, my mother's grave, everything they could swear to, possibly to try to prove it. Like he said he wanted to kill himself, and they say, "I never said that. Like, that's not what I said. She must have heard something." And then guess what? They go through with it after you leave.
Uh-huh.
Have been part of those calls, and those are just always ones that result in investigations, um, or those ones where the kid is really sick and you try to advocate that they should probably go. And going back to that, let's think about why you called 911 to begin with. Like
Mhm.
something in your gut told you that we should be here, right? But and sometimes those tough calls are like third party, where it's like a concerned neighbor called and was like, "Hey, I've heard this kid on the other side of the wall crying for 8 hours," and you show up and well, they don't want to go, right? And then next thing you know, the little kid is no longer with us, right?
Yeah.
So those are the ones that some examples that suck of like people who you can't force them to go, but you just got that gut feeling that something's not right. And yeah, in some of those instances, you can contact CPS, but we know, how efficient some of those services work and how quickly that works. Um, but yeah, I've been involved in a few of those cases where it was like the psychiatric patient that was manic at one point and now they're not when EMS is there, but they end up being found deceased or something the next day. Then then there's questions, especially when people
Yeah.
know, well, EMS was here last time. They were just here yesterday. And documentation and is the only thing to cover your butt.
Yeah. Um, because if you don't write it down, it never happened. Or if you
Yeah.
don't document it, never happened, whatever it is.
There was a quote, I have it in a documentation training thing that I did. It was uh even something like even the faintest ink is more clear than the longest memory, something like that.
Oh, that's good though.
Yeah.
That's really good.
Yeah.
Yeah.
It's pretty deep. I know.
That's when you should do the little applause.
Yeah. That's my favorite.
I feel like I'm about to start playing Drake after that. Um, I'm trying to think. That's really man, I mean, those are the biggest things I had, just the idea that they're not cut and dry. It's not, "Oh, well, they're A&O4 GCS 15," but when they try to take a few steps, they're so unsteady, they look like they have Parkinson's. Like, whole picture. You should still be doing a good history, still getting a good scene size up, getting sample, all of that stuff. Go with your gut, educate, make sure you reflect that it's the patient's choice overall anybody else's. And it comes down to even if it's above your own choice, above your own discretion, we have a lot of tools and tricks and supervisors and OLMC and this isn't decision making capabilities we have to think about, but also if a patient wants to go to the hospital, whether you're getting a refusal or you're showing up for um, at least you get paid at the end of this shift. If it's one of those kind of calls, it's the patient's choice. I mean, depending on if they're ANF4 GCS 15, not much you can do, but you can't document that their GCS is confused and all of this, and they had to go. That's called a lawsuit too.
100%. Yeah.
Patient was confused. No, she wasn't. You just started her with 300 of ketamine. So,
Yeah. Because I mean the the attorneys will find every loophole that they can and everything to make it, because if you didn't put in there that you said this, it didn't happen, and they can spin it any way they want to and tug on the heartstrings of those jurors.
oh yeah. So that's all I got. Be careful with your refusals. Don't be dumb. Do you want to add
Yeah.
anything, Ben?
No, I mean, yeah, cross all your T's, dot all your I's, document that you actually showed empathy to your patient and that you actually advocated for them, right? And you actually did an assessment, even if it was you felt for a radial pulse. Some super easy, really basic things can completely cover your.
I love all the noises and sound effects. Um, yeah, but oh man, I feel like there was something else, but I can't think of anything else. So, on that note, that's all you got. That's all I got. I appreciate you, Ben Tacy. Glad to have you on. If you want to go listen to a good podcast, go check out Profess EMS. God, I don't know where I was going.
Yeah,
Profess EMS. That's Ben's podcast. It's Master Your Medics. It's all of the good things. If you want actual education, head on over there. It's a good one. I'm a huge fan, just like Ben. It is so good. On that note, then if that's all you got, that's all I got. Appreciate you. And as we
Thank you
end,
as always.
oh yeah. And as we end every single episode,
The 22 at the Lips podcast is designed to support, not replace, the relationship that exists between a practitioner and his or her medical director. The views and opinions expressed in this podcast are those of the host, guest, and not necessarily of Master Medics. The information provided during this podcast is intended for educational and informational purposes only. It is not a substitute for your approved protocols.